The fields of orthopedics and traumatology are rapidly changing with the advent of new technologies and practices. But how can medical professionals ensure values are maintained in a time of building pressure? How can patient-oriented healthcare be maintained? To discuss these challenges, experts from around the world are meeting in Berlin for the German Congress of Orthopedics and Traumatology. In numerous sessions, talks and discussions over 4 days, they will connect with colleagues, learn more about new diagnostics, treatments and solutions for responsible patient care. At the largest European Congress in orthopedics and trauma surgery, 11,000 delegates will attend around 1,800 presentations on topics ranging from arthritis to trauma management, from complications to innovations. And to make sure you don't miss a thing, DKOU TV will be right here, bringing you the latest updates from the Congress. Welcome to the DKOU TV 2019. We're here at Messe Berlin to bring you insights into the latest developments in orthopedics and traumatology. We have an exciting program of interviews and in-depth reports coming up, focusing on everything from knee simulators to periprosthetic infection. We will be at the Congress every day to find out more about some of the sessions and events that are happening here, so stay tuned to find out more. But first, let's have a look at what's coming up on today's program. DKOU 2019 has a clear vision to promote the incorporation of values such as competence and humane treatment into practice. We spoke to some of the presidents of this year's Congress to discuss this year's motto, no knowledge without values.
We think knowledge needs values, and we think economic-driven medicine has to be stopped, and we have to focus more on the problems of our patients.
The patient is not visible in a lot of concepts anymore, so it is very important for us to follow or to bring the best practice to our patients. And that's why the values are so important. It is really difficult to decide for doctors, is the cheaper implant for the older patient, or what are the reasons to select an implant, what are the reasons to select a specific technique, or when is it okay to do an operation, or when it is too late. So that's some of these things we have to discuss, and that's what we tried.
We have also to work together with health insurances, with political parties who interact more and more in our work. And so we have to have values, and these values should not be or are not economical values. They are values for the patients. We want that the patient will profit from the work what we do for them.
Welcome to the DKOU studio, where I'm now joined by Dr. Michael Kraus, and we're talking about robotics in surgery. Thanks for joining us.
Thank you for having me.
So tell me, why is there a renaissance of robotics in surgery?
The question is, why do we call it a renaissance? In my opinion, robotics is just a consequence of the developments that we've been doing research on the last 20 years. When you think about that, navigation in orthopedic surgery now exists since more than 20 years in clinical settings. The question is, why did it take so long that robots are now coming into the OR?
Okay, so they've always been there.
They have been there, and the first robotic systems have caused some problems in the operation room, because at the beginning of such developments, you encounter problems that you didn't see right from the start. So surgeons and patients were a little bit afraid of machines. They probably didn't have all the right information they needed to perform the surgery well.
So are they not afraid nowadays?
the systems changed completely. Now the first robotic systems were more or less automated systems. They really performed critical steps of the surgery by themselves. And now we started with semi-automatic systems. So they're more or less just giving us guidance, and all crucial steps are then performed by the surgeon.
Okay, is this the most recent development in robot surgery?
Now the most recent development is that robotic systems can use much better data that are being created in the operation room itself. When you think about more or better imaging options that we have right now, like these huge systems that are doing CT-like images in the OR, and they're giving us new images and information that we haven't had for 20 years ago. And the robotic systems now, they use these informations, giving them better help to locate themselves. This is the base for robotic surgery. Without these informations, robots will never be able to assist us or help us. What they do not have at the moment is an haptic feedback, which we surgeons of course have, and they have no attention. So this is still a long way till a robot is being able to perform soft tissue surgeries.
Okay, but attention is one of the most important factors.
Yeah, so there is much more development necessary, like better software, better imaging, better guidance, and more tactile feedback for the robot.
What insight into patient outcomes are there?
I believe that robots are able to work more precise than surgeons are, and they can do this the whole day, the whole night. They never falter, they never have any problems. Like if you stand for 10 hours, probably your own abilities might not be so good anymore, and the robot, well, he's doing just a job.
So what developments do you predict for the future?
I think that in the future, these semi-automatic systems will become more and more automated, and I believe that especially the minimally invasive techniques that we develop at the moment will help to really then take robotic surgery on the next level. Like for example, in spine surgery, when you think about endoscopic surgery, this might be one of the future developments, that a robot is then for the first time able to not just work on bone, which is a rigid system, but also probably might be able to remove a slip disc by using these very minimally invasive accesses to the spine.
So it seems this will be interesting over the next decade also.
I think we will see some very interesting developments in the next decade, and the research we do at the moment might help to get this technology further on the way.
Okay, thank you very much for being here.
Thank you very much for having me.
Next up, we take a closer look at the Institute of Orthopedic Research and Biomechanics at the Ulm University Medical Center, where researchers focus on a broad research spectrum, including bone regeneration and joint biomechanics.
Unser übergeordnetes Forschungsziel hier im Haus ist die Erforschung von Störungen der Funktion und Regeneration muskuloskeletaler Gewebe. Natürlich mit dem Ziel, die Grundlagen besser zu verstehen, in die Klinik zu transferieren und letztlich verletzten und erkrankten Patienten helfen zu können. In unserem Institut arbeiten derzeit ungefähr 40 Mitarbeiter. Dazu kommen etwa 20 Studenten und Doktoranden. Wir sind hier im Haus ein sehr interdisziplinäres Team. Es arbeiten hier Biologen, Molekularbiologen, Mediziner, Tiermediziner, Ingenieure, Informatiker, und dadurch kommen natürlich sehr viele verschiedene Expertisen zusammen. Und wir haben ein sehr breites Portfolio an Methoden für unsere Forschungsarbeit zur Verfügung.
Unsere Forschungsschwerpunkte im Bereich Knochenbiologie sind, dass wir verstehen möchten, wie der Knochen auf- und umgebaut wird. Außerdem möchten wir die Pathomechanismen von altersassoziierter und postmenopausaler Osteoporose besser verstehen können. Außerdem möchten wir verstehen, wie mechanische Reize auf den Knochen wirken und uns dies auch therapeutisch nutzbar machen. Im Bereich Knochenregeneration interessieren uns die molekularen Grundlagen der Knochenheilung. Eines unserer Hauptziele ist, besser verstehen zu können, wie Begleitverletzungen und weitere Traumata die Knochenheilung beeinflussen können. Im Bereich Knochenforschung verwenden wir, um molekulare und zelluläre Mechanismen aufzudecken, in vitro verschiedenste Zellkulturmodelle, und in vivo können wir transgene Mausmodelle nutzen. Außerdem machen wir histologische und biomechanische Analysen, und uns steht ein hochauflösendes Mikrocomputertomographiegerät zur Verfügung.
Ich bin verantwortlich für die Forschung zur Bandscheibe, Meniskus und zum Knorpel. Die Forschungsschwerpunkte sind es, die Degenerationsmechanismen zu verstehen, Möglichkeiten der Regeneration zu finden und Therapiekonzepte zu verbessern. Eine Besonderheit unserer Forschung hier ist, dass wir ganz speziell entwickelte Modelle haben, in denen wir diese hohen Belastungen, die in diesen Geweben vorherrschen, simulieren können. Ein weiteres wichtiges Ziel ist es auch, neue diagnostische Marker für die Behandlung dieser degenerativen Krankheiten zu entwickeln und zu finden. Hohe Dehnungsapplikationen können wir machen, wir können hydrostatischen Druck applizieren. Und eine Besonderheit ist, dass wir mittlerweile auch viele Versuche im Organkulturmodell machen. Das heißt, wir haben Modelle, mit denen wir Gewebestrukturen für längere Zeit am Leben erhalten können, im Labor, unter Laborbedingungen. Und dann dieses Zusammenspiel von Belastung und Entzündungsprozessen beispielsweise simulieren können.
Ich leite den Bereich Gelenkbiomechanik hier im Institut. Der Hauptfokus liegt auf dem Kniegelenk. Speziell haben wir uns in den letzten Jahren auf den Meniskus gestürzt. Wir haben hier im Institut verschiedene Gelenksimulatoren entwickelt. Einen traditionellen, der mit relativ langsamen Bewegungen funktioniert und geringen Gelenkkräften. Das hat uns aber nicht ausgereicht. Deswegen haben wir in einem großen DFG-Projekt einen neuen Gelenksimulator konstruiert und haben dabei festgestellt, dass unter großen Belastungen und auch schnellen Bewegungen sehr viel höhere Kräfte entstehen. Zusätzlich zu den Gelenksimulatoren können wir Bewegungen analysieren mit speziellen Kamerasystemen. Wir können aber auch Gelenkflächen zum Beispiel biomechanisch abscannen. In Zukunft werden wir uns speziell auch auf die Rehabilitationsforschung stürzen und das können wir eben mit unserem neuen Kniegelenksimulator sehr gut machen.
Ich leite die Wirbelsäulenforschung bei uns im Hause. Ziel unserer Arbeit ist es, dass wir versuchen, die knöchernen Strukturen, die Bandscheibenstrukturen einer degenerierten oder verletzten Wirbelsäule zu verstehen, um dann Therapieverfahren oder Operationsmethoden zu entwickeln, zu verbessern oder neue uns auszudenken. Hierfür haben wir eine ganze Reihe von Belastungs- und Bewegungssimulatoren, um diese dann experimentell mit unseren Finite-Elemente-Methoden zu untersuchen. Wir versuchen in unserem dynamischen Wirbelsäulenbelastungssimulator ganz aggressive Bewegungen zu simulieren, die vielfach wiederholt werden. Und wir können damit unter aggressiven Testmethoden Bandscheibenvorfälle erzeugen, wie sie beim Patienten tatsächlich gefunden werden.
Wir freuen uns sehr, dass wir dieses Jahr einen großen Forschungserfolg erzielen konnten. Der Wissenschaftsrat hat uns ein Forschungsgebäude bewilligt zum Thema multidimensionale Traumawissenschaften. An der Antragstellung waren natürlich viele Kollegen hier am Standort beteiligt. Herr Professor Huber-Lang aus dem Institut für Traumaimmunologie und ich sind die Gründungsdirektoren dieses neuen Forschungsgebäudes. Zwischen 15 und 20 Arbeitsgruppen werden zu Fragestellungen der Traumaforschung zusammenarbeiten. Grundlagenforscher wie klinische Forscher, multidimensional vom Molekül über die Zelle bis zum Organismus und wir interessieren uns auch für die Interaktionen von physischem und psychischem Trauma. Nächstes Jahr feiern wir unser 30-jähriges Bestehen hier am Standort Ulm. Wir freuen uns, dass wir über die vergangenen Jahre gute Forschungsarbeit geleistet haben und unser Ziel ist es natürlich, das auch in Zukunft zu tun. Das Institut ist über die letzten 30 Jahre stetig gewachsen, die Mitarbeiterzahl ist vergrößert, die Forschungsbereiche sind ausgeweitet, sodass wir für die nächsten Jahre keine Angst haben, dass uns die Themen ausgehen.
I'm joined now by Dr. Pumberger and Dr. Hughes, who will tell me more about surgical strategies and pitfall of adult spine deformity. Very welcome, gentlemen. Nice to have you here. Tell me, gentlemen, what's the most common strategy for treating adult spine deformity?
Traditionally, the most common strategy involves fusion or reconstruction, where we use instrumentation to put the spine back into balance. The challenges, however, with this technique is that the solution can lead to other problems. And one of the things that we're trying to figure out through research is how to prevent what's called proximal junctional kyphosis or failure, which is one of the biggest complications which leads to additional surgery in these types of patients.
Adding just from the medical point of view from the patient is that these surgeries are long procedures, very invasive procedure, and carry a very high risk profile by itself. So the procedure itself is dangerous, and the outcomes, they vary a lot depending on the indication, for example.
So is this a top topic at this Congress?
Well, I think this is one of the most important spine topics within the conference. So spine being part of course, orthopedic surgery, but we deal with some of the same challenges because we're dealing with bone and connective tissue, and trying to understand more about the biology of those structures is important as far as long-term strategies to improve outcomes.
And what complications can occur and how to manage them best?
One of the biggest problems that can occur after spinal reconstruction in the setting of adult deformity specifically is proximal junctional failure or kyphosis. And this is where the soft tissues or bone at levels that have not been instrumented fail. And this can happen in the immediate postoperative period, or it can happen years down the line. And what that does is it leads to additional surgery, which is not only expensive, but it's high risk for the patient to go through yet another revision operation. Our research traditionally is focused on making sure the spine is in the appropriate three-dimensional alignment, but the next wave or kind of future direction of this research is better understanding the connective tissue or supportive envelope around the spine. And so one of the things that we discussed at the conference today are kind of future developments in this area. So moving beyond just X-ray measurements and alignment, but further understanding things like collagen degradation, muscle mass support, and other connective tissue supports within the spine.
And this is what connects all orthopedic fields. It's not only the mechanics that was driven or was driving the research for the past decades, it's now biology. And the interplay of biology and mechanics will hopefully be the solution for many problems in orthopedic surgery.
How do you think treatment options will develop over the next few years?
Well, one of the things that we discussed today, and many different people around the world are working at this, is to better understand the spine support structures, meaning the soft tissues and muscle interplay with the bony elements of the spine. Once we develop a way to communicate this spine support score, for instance, we can then develop therapeutics or have therapeutic targets to hopefully mitigate this problem that can develop after surgery. And ideas that potentially could serve as therapeutics would be recombinant parathyroid hormones or other growth factors that potentially could improve the support structure before and after surgery.
So why is this topic for you personally interesting?
So to me, this topic is interesting because it's one of the major issues in spine surgery, especially in the deformity field. The complication rate is very high, and dealing with those complications and those patients is not very rewarding, to be honest with you. So at the end of the day, we want to improve our patient care, and it is important to further investigate how we can preoperatively work these patients up and see what we can improve with these patients or in this patient population before actually performing surgery.
This is really a key topic that's, of course, personally interesting to me and other spine surgeons, but as Matthias said, I mean, this is a very relevant topic across all musculoskeletal care. So I mean, we're dealing it from a spine perspective, but these same issues are at play in other trauma fields or in even joint reconstruction. So I think this is universally interesting. I think in spine we have a unique opportunity to study it because the spine is more sensitive to these forces that are at play in the other parts of the body.
Gentlemen, thank you for being here. Have a safe flight home.
Thank you.
And a lot of fun at the Congress.
Yeah.
Next up is the Department of Orthopedics and Traumatology at the University Hospital of Basel. The department stands out due to its strong team spirit and interdisciplinary collaborations with experts from other fields.
Wir sind hier am Universitätsspital Basel, der Klinik für Orthopädie und Traumatologie. Wir haben derzeit 7 verschiedene Teams, 3 davon sind wissenschaftliche Teams. Des Weiteren haben wir auch interdisziplinäre Teams wie das Infekt-Team oder das orthogeriatrische Team. Ein wichtiges Merkmal unserer Klinik ist, dass wir die organisatorische Trennung von elektiven und akuten Patienten beibehalten.
Was die ärztliche Arbeit betrifft, arbeiten wir aber eng zusammen. Wir haben gemeinsame Rapporte, wir haben Rotation innerhalb der Teams.
In unserem Team, Team Oberextremität und Team Unterextremität, haben wir 4 leitende Ärzte, 6 Oberärzte und 6 Assistentärzte. Wir haben ein Pheno, womit wir normale Röntgenbilder aufnehmen können, aber auch 3D-ähnliche Bilder unterwegs während der Operation aufnehmen können. Es gibt uns die Möglichkeiten, die Patienten besser zu versorgen und eine präzisere und bessere Reposition zu erreichen. Zur Behandlung von komplexen Frakturen haben wir die Möglichkeit, einen 3D-Druck von einer Fraktur zu machen. Das ist eine Pilonfraktur, ein Dachdecker, 4 Meter gestürzt. Nun machen wir einen 3D-Druck 1:1 und wir können dann die Strategie ganz präzise und genau festlegen, bevor wir im OP gehen.
Und was wir im 3D-Printlab machen, ist aus den Computertomographiedaten ein dreidimensionales Modell des frakturierten Knochen oder der gebrochenen Knochen zu berechnen. Und aus diesen dreidimensionalen Daten kann man dann ein 3D-gedrucktes Modell herstellen.
Der Fokus für unser orthogeriatrisches Team ist eindeutig die klinische Tätigkeit, die individuelle Betreuung des geriatrischen Patienten praktisch umzusetzen. Das umfasst zum Beispiel ein Delir-Screening, es umfasst ein Management von Malnutrition, eine standardisierte Osteoporoseabklärung, ein standardisiertes Schmerzmanagement, die wir speziell für die geriatrischen Patienten definiert haben. Traumatologe und Geriater gehen gemeinsam jeden Tag zum Patienten und beurteilen ihn. Wir haben auch einen kontinuierlichen Patientenpfad implementiert, sodass die Betreuung von hier, der Akutstation, bis in die nahegelegene orthogeriatrische Rehabilitationseinheit gewährleistet ist.
Das Team für orthopädische Infektionen konzentriert sich auf alle ambulanten und stationären Patienten, bei denen es zu einer Infektion im Bereich des Bewegungsapparates gekommen ist. Es braucht bei praktisch allen Patienten die Kombination des Chirurgen und des Infektiologen.
In der ambulanten Sprechstunde, da sehen wir die Patienten mindestens zu zweit, meistens zu dritt. Ein Orthopäde, ein Infektiologe und ein plastischer Chirurge.
Es ist in der Regel eine operative Therapie vorgeschaltet mit der entstehenden Diagnostik und der Behandlung des Infekts, der Stabilisierung von Knochen oder dem Austausch von Kunstgelenken und im Nachgang dann die Behandlung interdisziplinär mit Antibiotika.
In der Forschungsgruppe beschäftigen wir uns mit, wie Zellen sich organisieren können, um Gewebe zu züchten als Implantate für die klinische Translation. Insbesondere im Fokus von Geweben vom Bewegungsapparat, Knochen und Knorpel, um reproduzierbar diese Knorpelzellen zu züchten auf dreidimensionalen Gerüsten, um Gewebe zu generieren, die biochemisch, biomechanisch funktional sind.
In unserem großen Nase-zu-Knie-Projekt führen wir aktuell eine multizentrische Studie durch. Wir haben große Hoffnung in diese Therapie für die Zukunft. Erkrankungen am Knie wie fortgeschrittene Arthrose, die wir bis heute nicht gut behandeln können oder wofür man dann ein künstliches Gelenk implantieren müsste, hoffen wir, dass wir das in Zukunft auch regenerativ mit solchen gezüchteten Knorpelkonstrukten behandeln können und damit Patienten auch helfen können. Wir haben bereits 2 Patienten schon mit fortgeschrittener Arthrose als Einzelfälle behandelt und haben hier sehr gute klinische Ergebnisse erzielen können.
Vor der Operation war es dann wirklich so schlimm, dass ich wirklich die Treppe hochgekrochen bin. Ich wusste für mich eigentlich in dieser Situation, ich habe eigentlich nichts mehr zu verlieren. Man hat mir dann hier in der Nase den Knorpel entnommen, den wir hier reingemacht haben. Seither kann ich problemlos spazieren gehen, also ohne Probleme auch mal Stunde, 1,5 Stunden. Ich sage ihm, ich habe wie ein zweites Leben bekommen eigentlich.
Der Fokus in der Weiterentwicklung unserer Klinik wird sicher auf der Optimierung unserer Behandlungsabläufe liegen. Wir verlegen die Behandlung, die ambulante und die stationäre Behandlung unserer elektiven, orthopädischen, planbaren Patienten ins Bethesda-Spital.
Der Fokus der universitären Orthopädie am Standort Bethesda ist primär das ganze Spektrum der Orthopädie. Das Besondere der Abteilung ist eigentlich, dass wir hier das Beste von 2 Welten anbieten, der Public-Private Partnership. Wir haben einerseits das individuelle Umfeld des Privatspitals für die Patienten, andererseits aber auch die universitäre Orthopädie, die hier einen 24-Stunden-Service bietet, mit der Qualitätssicherung, die man von einem öffentlichen Spital kennt.
Die Auftrennung in Elektiv- und Notfallbehandlungsabläufe birgt natürlich ein bisschen die Gefahr, der Aufsplitterung der Klinik. Wir sind aber so organisiert, dass die Spezialisierung im Fachlichen erst ab Stufe Kaderarzt stattfindet. Die Assistenten und die Oberärzte sind in einem Rotationssystem organisiert. Wir sind hier eine Universitätsklinik und wir nehmen diese Verantwortung sehr ernst. Wir sind überzeugt, dass die Weiterbildung ein Wert an sich ist, nach dem wir uns richten. Und man kann sogar sagen, die Weiterbildung ist eigentlich das, was unsere Klinik zusammenhält.
DKOU 2019 is a place for learning new skills and enhancing expertise. Delegates have the chance to brush up on surgical skills at the Trauma Academy, where renowned surgeons host education sessions on a variety of operations.
The focus of this Trauma Academy was in my session tibial head. It was a pre-fractured bicondylar tibial head fracture. It's great to have the Trauma Academy at the DKOU because you can create a realistic surgical setting with a realistic scenario of a fracture, and this can be treated and observed by a lot of people which observes the session, and I think this is one of the highlights of the Congress.
It's really great to have a Trauma Academy at DKOU because you can show the participants a new possibility to train orthopedic trauma surgery. We have the pre-fractured specimen, which is really a novelty in the field of orthopedic trauma surgery. The focus of the Trauma Academy, particular for our session, was to do an osteosynthesis of an acetabular fracture in a pre-fractured anatomical specimen, which is quite unique because usually if you go to, let's say, training course, you never have the possibility to get a cadaver where there's already a fracture in it, but the soft tissue is still intact.
So we want to train acetabular fractures on pre-fractured specimens and especially introduce new implants like the suprapectinal and infrapectinal plates that are anatomical plates for the treatment of acetabular fractures, and we can show a wide range of people how to work with these special implants. We have a lot of people working together on one project, and they see how innovations came into the clinic and how we work with it.
Up next, we take a closer look at trauma care in the Southwest Netherlands. Find out more about the work of the Trauma Center in the region and the Trauma Department of Erasmus MC.
The Trauma Center is an organization responsible for the trauma care in our region. There's one level 1 trauma center. This is the Erasmus Medical Center. We will see each year about 450-500 polytrauma patients. In the Netherlands, we have 4 helicopter medical teams, 1 in Rotterdam. As a level 1 trauma center, we have all physicians staffed on the helicopter medical team, and they are very experienced in trauma care and non-trauma care but for critical ill patients.
I started with a project of providing pre-hospital thoracotomies, which is quite unique for the Netherlands. We now are researching if REBOA, resuscitative endovascular balloon occlusion of the aorta, is another option. The average rates of survival for emergent thoracotomies are similar to South Africa and the USA, and that's mainly due to the collaboration we have with our Ministry of Defense.
The Erasmus Medisch Centrum has a close and very active collaboration with the Ministry of Defense, with the Armed Forces. We bring our war experience to the hospital and can use that in this very large trauma center. Also, we can keep our skills up to date, obviously. So we work with everybody, and we normally work in white, like everybody else here.
In the Netherlands, the trauma surgeon is head of the trauma team, and he is experienced in fracture care, but also in soft tissue and thoracic and abdominal trauma. We do damage control laparotomy or resuscitative thoracotomy, and also intervention radiology is possible 24/7 a day.
We do a stabilization in the ER department and subsequently
We have OR facilities at the ER, in the OR. We have intensive care units or in stable patients a ward. The team consists of 8 consultant trauma surgeons, so we are quite a large team, but on top of that we have pillars, certain specific expertises, and we have organized that in teams who take care of specific parts of the body.
In our hospital we see many multi-traumatized patients, so we have a very low threshold to do a CT scan of the thoracic cavity. I'm especially focusing on the presence of rib fractures. Rib fractures are, up to me, underestimated, and we need more data on how to treat these fractures. That's why we set up a multi-center randomized controlled trial for multiple solitary rib fractures. To operate on them, and the other arm, we don't operate on them.
We see approximately 80 to 100 patients with a pelvic injury a year that need surgical treatment. And we have a hybrid OR in which we can perform minimally invasive treatment with high-end, high technical resolution and software that provides us the possibility to be very precise in what we do.
We have done some RCTs, a randomized controlled trial on proximal humeral fractures. And for example, for elbow injuries, instability of the elbow, we will treat this with an external fixator, a dynamic one, with immediate mobilization afterwards, because we like to prevent stiffness. And we have very good outcome and satisfaction of these patients.
With regard to lower extremity, especially the lower leg, we have an excellent collaboration with our plastic surgeons, and even in the middle of the night or at the weekend we have the opportunity to do a definitive treatment in a very early phase. We have research projects going on, for example the effect of certain nailing techniques with regard to complaints on the long term. We also have been involved in the development of specific new implants that are antibiotic coated.
One of the other projects we started about 2 years ago is the osseointegration program. The procedure of osseointegration is when we use titanium implant. The femur is reamed to the diameters of the implant, and the implant is put press fit into the femur, and then by partial loading the bone will grow into the implant, and then the patient is able to move his prosthesis and there's no need of a socket anymore. Surgery is only a minute part of the procedure. Real work for the patient, the rehab program, it takes about 3 months at least.
We have a collaboration with the Technical University of Delft to see if they walk better, just the quality of walking, and if they can walk longer. We also do training programs within Europe to learn how to do the osseointegration procedure and the screening before the surgery and the rehabilitation program afterwards.
I had an operation 2 years ago and I'm happy with it, what I have now. With the other operation that I have, the symptoms was very painful. With this you can walk freely. I can on the bike, I can shopping, I walk on the stairs. The quality of life is back to me. The socket is gone and the pain is gone.
We also see many patients who are referred from other hospitals with problems with fracture healing, like infected non-unions or bone segment defects. This is a circular fixator which you can use with an infected non-union, for example. Also in patients who have a post-traumatic limb deformity. And then with the rings and a computer model we can adjust the position of the fracture. There are not many hospitals in the Netherlands doing this, so I'm quite proud to be able to do this.
We are also participating in international education programs. We are running courses together with international colleagues. We are also going to visit other hospitals to stay in the front line of the treatment of trauma patients.
I'm attending the DKOU because it's a great conference. It's the most popular conference in Germany, and yeah, I hope to learn a lot.
I'm a medical student in my final year, and I'm hoping to get some ideas for my future job, and I hope to specialize in orthopedics, so this is kind of getting some inspiration.
I'm attending this congress because I'm interested in innovations in surgery. The most interesting topic here is surgery on the knee, especially prosthesis and cruciate ligament.
I am interested in arthroplasty. We come here to know the most knowledge and recent knowledge in arthroplasty.
This congress improved my work, very improved.
I'm attending because right now I have time to do it, and well, I'm a student, so I just want to get introduced in how this congress is going to work.
I'm here because I like listening about the new scientific stuff, really interesting themes, really great presenters, all the great professors, and so it's like just to be up to date and see the new developments and everything like that.
I attend the congress because I'm an orthopedic surgeon specialized in children's orthopedic to get new facts about my field, and I'm all to be inspired and to meet colleagues which I didn't see for a long time, and I'm really happy. It's an amazing big venue here.
That's it for today from us here at the DKOU TV. We hope you enjoyed today's program and make sure to watch again tomorrow when we will feature interviews on geriatric traumatology, the newest trends in orthopedics and much more. Remember, you can watch the show in a whole host of ways, right here at the Congress, in your hotel room at select hotels, and of course online via the DKOU 2019 website and our YouTube channel. We will see you tomorrow.